Hall N. So this is the instruction course on communication pearls in ophthalmic practice. As you know, it cannot be overemphasized that communication is a key for the success in your ophthalmic practice. And the unfortunate part is there is no curriculum in most of our medical training to train anybody in communication. We normally go by our own innate qualities of communication and learn in the hard way how to communicate better. And it's always said that a bad communication always invites trouble, and a good communication is always an easy way, and you can probably circumvent many problems in your as you go along in practice. How to communicate with the patient, sometimes the parents of the patients, the media, the relatives, the colleagues. I think every communication becomes very important, and here we have some of the best brains in ophthalmic practice, and we have a host of topics which will be covering as all aspects of communication pearls. So we have Dr. Kirti Singh. Dr. Kirti Singh is a professor director from Guru Nanak Eye Center, Maulana Azhar Medical College, New Delhi, and she has done a lot of work on the basics. She has done a lot of undergraduate studies. She has done actually basic research on communication teaching in postgraduates and undergraduates. She'll be talking about the tracing the roots of bad communication. And we have Dr. H.M. Ravindranath, who's running a very successful ophthalmic hospital in Davangere, Karnataka. He'll be actually talking about some of the actual real situations, like what are the goof-ups that you when you communicate in ophthalmic practice. He will be giving some of the real life situations, and I'll be talking about a very common scenario of communication pearls in cataract surgery situations. And we have to add more masala to this, the wit and sense of humor that is so important day-to-day practice by none other than Dr. Quresh B. Muscati, a very well-known ophthalmologist and a former president of AIOC. He will be coming in soon. And we have communication pearls for young ophthalmologists. So a lot of postgraduates here. So what young ophthalmologists should know about the communication pearls by Dr. Deepti Joshi from M.M. Joshi Eye Institute, Hubli. And we have Dr. Madhav Ambekar from Maharashtra, who will be actually talking about a very important part of this communication, that is the how to break the bad news. So many a times we end up goofing this up, and it leads to a lot of problems. So how to break the bad news in day-to-day practice. So with that we will start with Dr. Dr. Ravi, have you loaded the presentation? Huh? Or you have the pen drive? Yeah. Can you just set his presentation up, please? Communication skills, and that has contributed to a lot of success in his practice. He's a very successful practitioner in Karnataka, and we just expect a lot of pearls from him, and also in real life situations, how communication goof ups actually create problems in day-to-day practice, and how to circumvent that. We have 10 minutes, Dr. Ravindranath.
Everyone, nice to see at my name, at least some faces here. Thank you, Dr. KP, for the opportunity. Thing is, you must be wondering, an average student doing very well in practice and a gold medalist from a prestigious institute struggling to get patients. This is a scenario in many places you must have come across. If you ask what is the reason why this is happening, so the answer lies there. That is how well they communicate. Communication is just how accurately the information is transferred. It's not just uh, the transformation of message to one brain to another brain. Who this? that is a this short video just for the funny video for the communication. Just play the directly video. It's there. It's there directly. One more video is there directly. In that folder is there.
If it is in the pen drive, we can
No,
play that. Yeah.
it's there actually. I think many people must have seen this short to just 10 seconds clipping. Wait here only.
Take one. What is it?
Bone marrow aspiration needle.
Good. Okay.
Thank you, sir.
Good luck. My
Best of luck.
studios.
Thank you.
Take one.
No, it's okay, sir.
ഇതെടുക്കാതെ വൈവ മുന്നോട്ട് കൊണ്ടുപോകാൻ പറ്റില്ല. Take one.
So this what happens if you really don't understand what the other person means. Biggest miscommunication history is when Arjuna wins Draupadi over Swayamvara and Kunti judges differently, and this is what the history. So this is the biggest miscommunication history. What are the root causes? If you come back to the communication goof-ups, what are the thing is assumption. You assume that whatever you have understood is being conveyed to the other person. So you assume the message. So that is the biggest problem. Second is in our clinical practice, lack of time. You are in a hurry and lack of concentration. You don't communicate well. Lack of knowledge and lack of clarity also contributes to this. And underestimating or overestimating the other person's knowledge, other person, and sometimes language barrier. So in coming to the clinical scenarios where all it can happen is, one of the common places is at waiting lobby, where I'll explain what problems I will be facing in my clinic. Lack of clarity at waiting period. So patient comes, he'll be waiting in clinic, OPD launch, and person who has been operated yesterday will directly come to your consultation chamber and walks away. So this irritates those people who will be waiting for half an hour, 1 hour. So if there is a lack of clarity in waiting period, it really creates problem. And dilating the wrong patient. Sometimes, we have similar names in our area, like you have Manjunath, you have Malikarjun. So you call the name of the person, there will be 2-3 people of the same name, and you directly dilate other patient. Or sometimes dilating the attendants. This happens. He'll be sitting beside, and the optometrist go and dilates the attendant side. This also happens. If you come to the consultation room, the biggest embarrassing thing I have faced is assuming the relations. So a couple of similar age, of same age, come sit in front of me, and I think they're, earlier I was thinking, so we take it for granted they are husband and wife. And you start explaining in that language that's not correct. No, if there are two people of different gender, kindly confirm the relation before you speak. This is sometimes they'll be brought by neighbor, friend, or sometimes brothers and sisters. So this really embarrassing situation. And being blunt on explaining the prognosis. So earlier I was doing that. If you see optic atrophy or age-related macular degeneration, you straight away say no need to come again. No improvement will be there. So this type of blunt statement should be avoided, and to be very diplomatic and sensitive for the patient. And this optic nerve and retinal disorders, many times they'll end up with a neurologist saying that when you say there's a problem with your nerve, they think they'll go to neurologist because there is some problem with the nerves. And chronic diseases which repeated visits are needed, they'll end up with quacks or other pathis. Pre-operative counseling is also important before doing surgery. Avoid using too much technical words like what type of lens you need implantation. You don't tell that you need a single use hydrophobic with square edge, will put in the bag, improves the contrast. no PCO, those kind of too much technical words to be avoided when you are talking to the patient. And don't focus too much on machines and implants, and try to focus your surgical skills and experience. And avoid using scary words like, when you're talking of vitrectomy, I've seen one of the fellows explaining, we'll make 3 holes in the eye and put a torch in one hole, and another hole we'll put a water pipe, and another hole we'll put scissors and cut the blood inside. So these type of scary words should be avoided. And over-promising. See, we have somehow, in the attempt of getting more patients, we are oversimplifying our surgery and over-promising the results. Like when they say, what precautions you should take after cataract surgery? Say, no, nothing, it's just 10 minutes procedure. You come just like you come to parlor, or 5-10 minutes you lie down, work is over, then next day you can go back to your work. So those type of oversimplification, if you do, it is very difficult to explain the complications if you face, because complications can happen in anybody's hands, So this things, and one of the things I frequently come across is missing out the near vision expectation. Most of the time still we implant monofocal lenses, and we fail to say that patient will need near vision glasses after surgery. And next day, if you have not told clearly, patient will be very unhappy, because that is one of the things they are expecting after surgery. OT manners are also very important. In OT, don't be casual in OT, because see, you are operating, that eye is one of your eyes, 1,000 eyes you operated. But for that patient, it is the only eye which is getting surgery on that day. So don't be very casual. Talking with your colleague other than his eyes is very difficult. Once I was talking to my colleague about who will become chief minister next. Then he said, "Oh, बाद में देखेंगे. You first you operate my eye. So concentrate my." People have told me that. People have told me don't talk other things when you are operating. So this you should. If you want to speak to the patient. Best is speak to the patient. Don't speak to your colleagues or OT staff, and don't talk other than about his eye. They'll think you are very casual. For you it's okay, but for the patient it's very important. And one of the things which I come across is IOL power and package cost. So see, in our OT, what pay, like loudly our OT assistant will tell, I am opening Technis 1 lens of 21 power. So patient will, many patient have told that you have taken 30,000, 35,000, they are opening 20 lens. So that is plus 20 is diopter, because they don't know what is diopter and what is money. So you should tell this is the power of the lens I am implanting in your eye. And don't talk about complications, and your behavior should not change when you end up in complication on the table. So they'll think otherwise. Post-operative instructions should be very clear. This is very important, because still after 20 years of my practice, I am still getting patients who have used wrong drops, who have underused the drops, overused the drops, misused the drops, wrongly used the drops, improperly used the drops. So still I am yet to find a perfect way of conveying the post-operative medication. If anybody has, please tell me. Still there are patients who come using different methods. And explaining the guarded prognosis, you have to be very kind and diplomatic. So like some words, common words in our ophthalmology, like laser, nerve weakness, lens. This, okay, I'll just finish. Enter. Yes. So this is one of the important things is I take blame of failure in follow-up of diabetic retinopathy patients, glaucoma, and late presentation endophthalmitis. Don't blame the patient, blame yourself. There is some of your fault in explaining the seriousness and clarity when patient doesn't turn up for the follow-up of diabetic retinopathy, glaucoma, and post-cataract surgery. So how to avoid? Focus, never assume things, be calm and composed and simple, have knowledge, attend workshops, training, accept and learn from your mistakes, cross-check things if you have doubt, and use technology. Thank you.
Thank you, Dr. Ravindranath, for really putting up all the real life situations and the problem that we face. Now we go on to Dr. Kirti Singh. She is actually both a postgraduate and undergraduate teacher in Maulana Azad Medical College, and she has done a lot of seminal work on inculcating this empathy as well as the soft skills in medicos, and she has done a lot of original research on that. So she'll be talking about a very pertinent point of tracing the roots of the bad communication. Why, as doctors, we communicate, we are a failure in communication, and how can you trace this pathology, this problem, to its roots? So over to Dr. Kirti.
Hello, this is not moving from here. It's not communicating with me, it's not moving.
Slides are not moving.
Thank you, Dr. KP, for
Okay.
having me here. No, it's not moving, beta.
Yes. Yeah, it's moving.
Yeah, now did you do something there? Yeah, now it's moving. You'll have to come and tell me. Excuse me, please. You'll have to come and tell me because honestly, we're wasting time.
Somebody be please there, no?
Back is which one? This is home. Yeah, this is home. Right. This is home. Right. Thank you. So, good morning to the few listeners, but that doesn't matter. As a teacher, I'm used to a classroom that's between 8 to 9 and only have 20 students where we should have 250 students. And you said कि 20 student के लिए class के लोगे. I said why not? 20 student आए हैं तो बहुत अच्छी बात है. So you 20, whatever listeners you are there, that means you are really interested. And kudos, that's enough. Okay, so thank you, Dr. KP, for giving me this topic very close to my heart. Tracing the roots of bad communication, and this is a picture of a tree in a very busy market in Delhi, and I don't know when it's going to fall. I keep looking at it, and that's actually what is the scenario with doctors, because we are forgetting a very critical aspect of our patient-doctor relationship, which is communication. So this tree may fall anytime, and it's going to be a casualty then. Poor communication. What is communication? Communication is improper transference of ideas in the current, and it's responsible partly for the current climate of medicine, which is disconnect between the heart, head, and the hands. We focus too much on our hands. We focus too much on our head. We forget there's a heart. Not heart for us, heart for communicating with the patient, because have God forbid you ever become a patient. I became a patient 2 months ago very badly, and I really remembered this lecture of mine. I'll tell you how. So, what is communication? Then second is you have to have an optical. It's not important just to communicate, just to tell the prognosis, just to talk to the patient. It's important to talk to the patient, all the relations, in a way that they understand and they feel connected. So, effective communication or optimal communication is important. It's just not saying, speaking, informed consent. It's not a tick box exercise. What is empathy? And that key to optimal or effective communication is empathy. Anybody, I mean, other than that's not empathy. Anybody knows what is empathy? The youngsters sitting there. It's very tough. It's very tough to put yourself in somebody's shoes. But please remember, your patient is not an eye, or your patient is not cataract, glaucoma, or retina. Your patient is an eye in a body who stays or works in a family, who works in a job, who has children, who has a husband, who has to know कि drops कैसे डालनी है. मैं drop डाल पाऊंगी. मेरे को arthritis. I mean, I have arthritis. I can't put the drops. Or I have dementia. I will forget to put the drops. Or I'm very scared of the disease. So all this the patient is feeling. Is actually feeling. So please understand the patient and not just the eye, and that's what's empathy in my language. So what are the roots? First is, as Dr. Ravindra rightly said, ignorance and a teeny weeny bit of arrogance. As surgeons, we are very confident of our skills, and rightly so. We've worked very hard at those skills. So, but we become a teeny bit arrogant, and the commonest cause of overconfidence or is that you kind of overestimate your abilities of communication. Like this cat is dreaming that she's a lion, she's not. Okay, so you don't overestimate. First of all, be willing to know that you need to know. Second is too much of focus on technological skills. How many of courses of KPs are there? They're mostly technology courses. They're mostly on surgical skills, complicated situations, how to overcome them. But Please remember, you have to have a patient for you to be operating. And to get the patient or to keep the patients coming to you, the best way is to communicate with them. So this is my anatomy class, a very favorite teacher of mine in 1981. So you now know my age. And this is the class of 2020. Okay, so too much of focus on the simulator, teaching by optical means, by surgical means, less connect with the patient, less connect with the subject. Second is very important. In our exams, in our training, communication skills are never assessed. And since assessment drives learning, it's never learned. Okay? So they're never assessed, and plus it's difficult to assess them. Time. Dr. Ravindran also said time and logistics. There's a very interesting study on OMP, 1 minute per sector. Okay, that's how we teach students how to examine patients in post-graduation. And there were studies which timed that OMP would explain discussion and with the patient would take just 2-3 minutes more than the actual. And one patient understood correctly will save you multiple hours of litigation later. So invest that time. So time and logistics, take it that this is part of the time. This X number of minutes I have to spend, this is part of my clinical examination. Very often we are R-centric. My OPD, my OT, my surgical skills, my reputation, me. Very or less we are patient-centric. So when we is replaced by you, it makes a big difference. Again, think, what does the patient need? Why is the patient come to me? You may do 10 surgeries or you may do 20 surgeries. At the end of the day, the quality of surgery and the quality of your patient connect will make your reputation. So even then, invest. These are all investment in your reputation or skill, whichever way you call it. Unfortunately, we are the victims of the modern communication, the WhatsApp guru, which is pretty superficial, sudden, unsifted, too fast for truth. This is not my statement. This is New York Times about telegraph way back in 1858. They thought telegraph is too bad. Now, it's so instant. We now want instant results, instant gratification. A very famous sculpture, which won the award 2019 in Amsterdam, it is aptly titled Addiction. And this sculpture came out of the phrase which has come up in Oxford Dictionary called as fubbing. Practice of ignoring one's companion or companions in order to pay attention to one's phone or other mobile devices. Currently, phones are our umbilical cords, but I don't know who the mother is. What are we connected to? If you don't see the person sitting next to you, but you want to connect to somebody who is very far away and you want to reply to WhatsApp instantly. It's an addiction. It's actually addiction. And this sculpture, remember this sculpture, it is actually titled Addiction. Okay? I don't know if my era people would be few, but whatever, you remember this very interesting movie.
आप तो समझने की कोशिश ही नहीं करते ना। अरे भैया, कभी-कभी दो बातें ना होते हुए भी हो जाती हैं।
Have you heard this movie? चुपके चुपके, very famous movie. कभी-कभी दो बातें होते हुए नहीं भी हो जाती है. And the very important message was, you don't want to understand. You really have a blind spot. It's like a Swan-Jacob syndrome. You don't want to see. It's a blind spot. You don't think it's important. Okay. So, what is important is non-verbal communication. Your voice, जो समझना नहीं चाहते, voice important नहीं है. How you are speaking. How is my body language? How am I communicating? I would need 2-3 minutes more. Otherwise, I'll just stop. Body language. Okay. Body posture, facial expressions, silence. Sometimes you don't have to speak all the time. Let the patient speak. Listen. Again, invest that 2-3 minutes for the ultimate saving of your litigation or your time later on. WhatsApp करेगा, phone करेगा, ये नहीं समझाया, वो नहीं समझाया. That time you waste. Okay. This is a beautiful sculpture of the hand gestures in the airport of Delhi. Just tells you the importance of how you move your hands. This is a learning. You have to learn the skill of talking, of non-verbal gestures. Any of you have had a cumin seed stuck in your teeth anytime? Something stuck in your teeth. What happens? We will keep. KP is doing that. You'll keep doing it. You'll forget what you've eaten. होता है? Very interesting analogy. This was, I sent it somebody, my editorial on empathy, actually, on empathy, and I forgot to remove that black bar. So what is, the person couldn't read what's written, right? So just gave me an analogy, and I remember this famous book which I had read about life's amazing secrets, and he talks about the cumin seed. Okay, mind is like the tongue. Default setting drifts towards negative. One negative word you've spoken to the patient, one positive word which you have not spoken to the patient. Patient will remember that and not the other things. So focus on that cumin seed. Okay, communication to be effective, speak same language as the patient peers. Verbal communication has barriers, as we just discussed. They may not understand language, Tamil, Telugu, Kannada, Hindi, Punjabi. They may not understand. Non-verbal communication transcends all barriers. How I talk, how I hold the hand, how I clasp the patient's hand. Do I give him a glass of water to drink if he's crying? Do I give him a tissue if he's crying? Okay? Do I do it? Not I tell my staff nurse to do it for me. Okay, I'll just do the last one. But this is the non-verbal communication. This needs no language. This child responds to the non-verbal clues or the dilemma of this rabbit. Okay, it doesn't need to be told anything. He doesn't understand, but he knows कि वो बच्चा गिरा हुआ है. This is the visual impact of your non-verbal communication. So doctor is not second to earth. We have to be good role models. 8Com module is part of your MCI or the NMC training now for undergraduates. We further out of it. This was our seminal work on role plays as an empathy education tools, because it's very difficult to assess empathy. Okay, and this is part of your transformative journey of blossoming communication skills with empathy to a final beautiful sunflower. Because read the reading on the wall. The wall writing is very clear. This tree can fall any day. It can collapse. This leading doctor-patient communication, the treatment is in our hands. Thank you.
Thank you, Dr. Kirti. That was a fantastic lecture. So now I'll be taking up the next very important aspect of day-to-day life, that is cataract surgery and communication pearls in that. So I'll try to probably catch up with the time that we lost. So as I told you, like, good communicators get into less trouble. It's a forgotten soft skill, and we have to make a conscious attempt. I think all the educators should make a conscious attempt to instill this skill in their formative years of medicos, and probably it's a lifelong learning for us. And obviously, I'm just probably concentrate on the surgical career of us, like when you do cataract surgery in particular, it definitely adds a value to your surgical outcome. You may do the best of the surgery. If you don't really communicate what you have done, it is assumed that, so they still have expectations. So you need to actually add in this communication so that you increase the value addition. Let me start with the second eye syndrome. For example, in the patient, it's always said that the person who undergoes the second eye cataract surgery, okay, is always left unhappy. He always says the first surgery was better. He always says that the second eye is not seeing as good as the first eye. And he always said that the second eye surgery took more time. It was more painful than the first eye. Why is this? It's because I got an SMS long back that all the problems in this world are because of two evils, that is comparing and expecting. If you don't compare yourself with anybody else, you are the happiest man. If you don't expect anything from anybody, students, spouse, children, AOC, conference, don't expect anything. Lunch, dinner, don't expect anything. You will be the happiest. So, second eye syndrome, both are working. Let's say the patient comes for the first eye, he only has fear. He has heard stories of things going wrong, so he only has fear. And Dr. Devendra operates him, patient, it happens in 5 minutes, topical surgery, patients, had so much fear, okay, it just got over in a jiffy, and patient is seeing very well because he's comparing his eye with the other eye which has a cataract. So the comparison, so he says, I'm seeing very well, doctor, you are a god, he'll say, and he comes for the second eye. When he operates, he's coming with now expectation. Okay, the second evil. So he's expecting it to be shorter, he's expecting it to be painless, expecting it to see the moon. But now, once he comes with any expectation, you're always left unhappy. And he compares his second eye vision not with the third eye which has a cataract, with the first eye which is already recovered and seeing well. Okay, that means there is a wrong comparison here. The first eye was compared with the cataractous eye, the second eye with a pseudophakic eye. So he will always say my second eye. So you always have to keep this in mind. Many a times we botch up the whole thing by just not telling this. So I tell my patients, your second eye is going to take more time. Your second eye is going to be painful. Okay, you're not going to see less and much more slowly than compared to the first eye. I say why? I say it's psychology. It happens to all the intelligent people. Okay, so I'm not really stepping on the toes of Dr. Madhav Ambedkar's talk that he's going to tell the real in a bigger perspective in a cataract surgery. Like you go to a OT, you tear the posterior capsule and the nucleus drops. So what will you do? So you have a list of 12 cases lined up. Okay, you're all, so you say, अरे मेरा case खत्म करना है, सब patient wait करे, तो ऐसा करो, take this patient, give them a special room, give them coffee. I'll finish my list, go at 2 o'clock and sit with them for 1 hour and explain the whole family what is it and what we'll do next. That should never be done. Okay, because all our patients and their relatives are fond of Bollywood movies. What's a typical OT in a Bollywood movie? There's a closed door, there's a red light blinking, people are moving front and back, and the door opens, suddenly the surgeon comes out without wearing a cap sometimes, without wearing a mask, wearing a stethoscope, some nonsense. He comes out and delivers a judgment. He says, बच्चे को बचा सकते नहीं तो माँ को बचा सकते. Or he will say, 24 घंटे में होश नहीं आया तो बस खत्म बात. Some life-shattering judgment comes after the door opens. So they are mentally prepared to hear the bad news in that premise. Okay. Not that I take them to the comfort of the room and the doctor comes after 4 hours and says, sorry, we could not put the lens, the nucleus dropped, I have to call Dr. Devendra to take it out. No. The period of vulnerability is gone. So what you do is, you drop the nucleus, no problem. Go in your attire, there's a semi-sterile, sterile area combination, call them there. They come like lamps, you're sitting all over there towering. You say, okay, we opened the cataract, we found the support is not too good, so we need to, there's some problem at the back, so I will probably get in a new surgeon to take this out, then we'll probably try to do it. So don't worry, everything will be fine. So that is the time where you are in control and they are susceptible and they are able to take the bad news because they are already mentally prepared for that. So that is how things go. So never, delay breaking the bad news, and you always tell it then and there, and things always happen fine. And normally, you see, you always do a good job at the end. Patient always sees better. But don't try to create a problem right in the beginning. Okay, multifocal mania. See, it is so difficult to convince a patient for multifocal. You put a monofocal patient, as he said, where is the mujhe nahi dikh raha hai. You put a multifocal, he says he sees rings only, nothing else. All the positive is gone. He is reading a newsprint, but he will say, mujhe ring dikh raha hai, wo dikh raha hai, ye dikh raha hai. So basically, there is always a problem. So how do you actually convince a patient? What is the 1-minute counseling for a multifocal? I say, choose between these two. See, if you want, what do you want? You want clarity, you want convenience. If you want the clarity, you want a crisp vision and ready to take a 5% of inconvenience of wearing some thin glasses once in a while. Use the words properly, okay? He says, most people will fall to this trap. They say, mujhe clarity is. I'm already wearing glasses, no problem. Kabhi kabhi pen leta hu. So then he will not tell, mujhe nahi dikh raha hai. And especially with a good monovision principle, nowadays people are very happy. I'm personally a fan of monovision. At the same time, you say, no, I don't want to wear glasses. So if you want the convenience of complete spectacle independence, you need to take a small, shot at the clarity. 4 to 5%, or you may still lesser, 3%, 2% loss of clarity at times. So if he says, thoda dhundla hai, all that problems of photic phenomena and loss of contrast should be coming under this. So you said you chose clarity, wear glasses, you chose convenience. So basically, trying to simplify and so that you can understand the personality. See, you don't have to give the choice to them. You induce them to pick up one depending upon what you think will be ideal for you. So that the patient is also a part of decision making. He will not hold you responsible later as a sole entity. And we are underselling always. See, you have to have a counselor. If you have 15 patients in your clinic, you should have a counselor. It's a well-paid thing. And frequently asked questions have to be answered. The counselor has to only confuse. you need to take the final call. And don't sell the IOL, sell the surgeon, sell the skill, sell the experience and the expertise, not the IOL. I think this is a very bad trend that we are normally, it's ruining the practice actually. And final shot, this is the final nail in the coffin, endophthalmitis. I think the art of managing an endophthalmitis becomes equally important like the science. The present day vitreoretinal surgery is so advanced that we always get very good result. The patient comes in time. There's never been a problem like the past. Okay, but the problem is that we mess up with the art. All the problems so far in our history are all because that we manage the art wrongly. Okay, so it's not the end of the world. It calls for both art and science. Accept it. Don't say it's a task. Accept it, fall in line, and start doing things quickly. Everything is endophthalmitis unless proved otherwise. But for the patient itself, you promise the moon and he's not seeing anything. There's a pain, discomfort. So you are a demon. You're immediately demonized. The person who said you're God will reverse the wordings immediately. Okay? And it's a critical, he says you're no good. It's an evaluation of surgical competence because of a bacteria which attend into the eye. So how to handle? Take it immediately. Don't make them wait. If you know that at the reception there's a problem, patient who came 3 days ago for surgery, now seeing less, take care of them. They may wait, you may be seeing a VIP, you may be seeing an emergency. If you make them wait for 15 minutes, in the court of law they say 2 hours we waited. They will add the time they started from home also. Okay, 2 hours the doctor didn't care. Okay, so that will be the version. And also make it private. No, don't call in front of other patient what happened. He will say, आपने operation किया अभी नहीं दिख रहा है. So take it private and show concern. At the same time, you don't have to bend backwards and show that panic and that guilty attitude. No, so you don't have to feel that guilt. See, be firm, but at the same time be compassionate. It's important. They're in trouble, and ask them when did the blurring start. Normally, topical surgery, most surgeries, they see very well immediately post-surgery. Even if you put a bacteria, it takes 48 hours to invade the vitreous and the vision should drop after 2-3 days. So patient would have seen for 2 days. If the patient doesn't see immediately after surgery, the problem is with the surgery. That's what they think. It happens after 3 days. There may be anything that has happened in 3 days. So you ask them, what happened? Did you sneeze? Did you cough? Or did you rub your eye? Somebody elbowed your eye. So something would have happened. You saw a serial and cried. So that means there is some contributory thing from their side which could be responsible. That's a kida in his head. No, you just put it there. Then he suddenly starts thinking, "Arey, wo bhi ho sakta hai." I think that happened. So probably it's not. It's just that you divert that you are not there at the. So lastly, don't use the word infection. Very, very important. You say it's a reaction. Severe reaction in aankh mein. Inflammation is also a reaction. Okay? And don't show so much of despair and take the hostility head on. This is important. And be genuinely interested in the welfare of the patient. That is very important. From your heart. Okay? Don't be so fake. From your heart, you try to do things at the same time, be defensive also. Okay? Just hold on to your nerves. In India, most of the things end with a happy ending. Okay? And always prevent a lawsuit. You may be all that may be in your favor, but still it's a waste of time and resource to go to the court and win it. Prevent it. Okay? Anticipate, keep your everything ready. It's very, very important, and hire a good advocate, because law is a slave of evidence. If you don't have evidence, no documentation, nothing, including the consent. Okay? So thank you very much. Now we'll have Dr. Deepti Joshi. She will be speaking for what are the communication pearls that we need to teach our young ophthalmologists or postgraduates and residents. So there are a lot of things that they should know in particular, because the practice and the experience teaches a lot. But since they are at the portals of this great ophthalmic fraternity, what they should be learning in order to... Yeah. Yeah, I just visited one hospital in Hyderabad. Okay, they had 35 packages. Like you go to Sagar restaurant, Delhi, they have around 55 dosas. Okay, so it's like that. So basically, you are basically creating a problem and putting, because everything is only difference of 2-3,000, 23,000, 25,000, 30,000, 32,000. You have to create some, different benchmarks, okay, for a type of patient that who is coming to you. There should be something for everyone, and don't undersell. Don't undersell. Something for everyone. At the same time, I think you should not have more than 4 or 5 packages, depending upon the kind of patient that you are seeing. So it's not really necessary to have all the kinds, and don't put the whatever the company says in the brochure. Don't put them as per square edge. Okay, and the price will speak for the quality. See, you don't know what is in I-20, what is in I-10. You go for the budget. They will say 100 things, the car seller. So you decide, mere paas itne paise, I'll buy this car. Okay, unless you are an expert. So most patients do not know that. So I think the money speaks for the package, not the qualities of the IOL. I think you have to always have the final word. Yeah, Dr. Deepthi.
Hello everyone. So welcome to this communication IC. Thank you Krishna Prasad sir for including me. With HMR sir, I would like to tell one small event he told me about. Just told us about the drops being put in somebody else's eyes. I think I am a pediatric ophthalmologist and I prescribe atropine normally for checking the refractive accomodativities. And it so happened that the very next day I received the call from the dad. Madam, मेरे आंख में लाल था, मैंने डाला पूरा धुंधला है. I said अभी और 14 दिन धुंधला रहेगा. It is so that day I actually realized. From then I not just explain twice a day for 3 days. I tell घर में किसी और को आंख लाल है तो इसको मत डालिए, ये सिर्फ टेढ़े आंख का टेस्टिंग के लिए है. टेस्ट होते से ही फेंक दीजिए. So I think these small things really matter and which we pick up during our own practice. So with this now I start my IC, a communication pearl for young ophthalmologists. Very few young ophthalmologists, PGs over here. So this is something which is totally video based. So this is a scenario 1. So what was lacking here? The patient was trying to tell her complaints and the postgraduate bar fellow wanted to just finish her work. So there was nothing called listening, she was just hearing. Listening is a art, hearing is just a physical thing. So it is considered that when you open any communication presentations in the YouTube or in SlideShare, it is told that listening is the most difficult skill to acquire. It requires lot of practice. Keep your minds open as you listen. There are many times when the kids enter my OPD, I see their eyes yellowish. I know it is a case of VKC. I know it is an allergic conjunctivitis, but then there could be a hidden post long-term usage of steroids. There could be a hidden glaucoma over there. There could be a hidden astigmatism over there. So we need to listen what other complaints have the patient come to us despite the clinical signs being very evident. And if we have had a real tired day and we are really tired to talk to them, at the max, I think we can respond by a simple nod and okay, or just maintaining an eye contact with the patients or the parents in the room actually makes them happy that she is looking to us. Back of the brain, kuch bhi chale, unko pata nahi chalta hai. Keep listening to them. I think that makes half of the half of their treatment done. They go back very happily. So now this is the second scene. From the OPD, I go to the OT.
बोला था ना तुझे छोटा एक्सेस नहीं करने को. हो गया ना अभी कॉम्प्लिकेशन. अभी क्या करेंगे? रुक, मैं वॉश होके आती हूँ फिर देखते हैं. ओके?
Now imagine the patient situation. She told, "Arey yaar, shit." So he knows his condition is, yes, I think so that word explains it. And she said drop ho gaya. So the patient again knows there is something which is dropped now. And the third thing, the one who was supposed to assist her, bola tha na chota rexis nahi karne ka. So she said the mistake is the doctor's. So the patient whenever one sense organ is not working, the other sense organ becomes very, very active. So it's just that the eyes have been closed by the drape, but the ears are super active of the patient. So every small thing, whatever we utter in the OT, actually carries a lot of impression. The patients carry it back. So many times they come and ask us, like, Madam, आप लोग ये बोल रहे थे, इसका क्या मतलब है? आप लोग वो. So when we're seeing the post-op, we realize they have heard everything, whatever we have discussed in the OT. So try keeping the operation theaters as formal as possible when you start doing the same, and unnecessary talks, unnecessary words have to be avoided as much as possible in the operation theater, be it your consultants who are operating or you yourself who are operating. Take care of this one aspect. The next would be my next scene. I again shift back to OPD. So, in the era of litigation, when every single word what we utter can be taken against us, just telling the patient bluntly, without any emotions, without any empathy, that the patient has got an infection, नजर नहीं आएगा, जो हर जगह जो infection होता है वो तुम्हारा आंख में भी हो गया है. So for us, yes, it may be a simple task, it may be an endophthalmitis. We know we have our own retina setup, we know that things can be cleared, yet still for the patient, for the patient's attenders, that is a major thing. They have paid for the cataract lens, they are expecting something wonderful out of the hospital. So every word what we say in front of them actually can backfire. So these are the multiple articles which say that patients, moment we say there is a loss of vision or there is an infection, such things can happen, the media can take place. So what differently could this thing have been done is, okay, so that small act of pani chahiye aapko and making the patient comfortable is what matters in our OPD. So I think what ma'am stressed over here, Kirti ma'am, empathy. Just put yourself in the shoe of the patient. Tomorrow I may undergo a cataract surgery, tomorrow I may develop an infection. So that is the thing, my own parents can do the same and that can happen to them. So putting ourselves in their shoes actually makes us feel a bit empathetic. So rather than being blunt to the patient, rather than using the words like infection, a small shift in the word like reaction maybe can put you in a safer aspects as an younger ophthalmologist, as a young ophthalmologist. As such, the young ophthalmologist, we don't look really old and people really think that we are in the hands of a young ophthalmologist. This is really, I think I have faced it for the past 10 years. Even now people ask me, आपके बच्चे हैं, आप हमारे बच्चे को देखोगे ना अच्छे से. I have put a family pic in my OPD कि मेरे शादी हो गया है, मेरा 2 बच्चे हैं, मैं बच्चों को संभालना जानती हूँ. So I think these are few things which patients really, the age, the baldness. My fellow who was bald used to receive more patients than me because people used to think he is older. So young people, every step what you take, actually, okay, HMR sir, I didn't mean that. So
No, not that.
okay, this is
not
the
photo.
time constraint.
Not that. Please crop me if you're putting that photo and edit something, do something, put some beauty face, do something.
Look at his
okay,
face.
I'll get back to you in some time and I'll send you one more photo which you can put. चश्मा निकाल ली? क्या हुआ?
आंखों से पानी जा रहा है डॉक्टर वो.
इधर आना एक बार. ये सब कब से हो रहा है?
10 दिन हो गए डॉक्टर.
हाँ, ठीक है. कुछ दवाइयाँ ले रहे हैं क्या?
नहीं कुछ नहीं डॉक्टर.
Hello? Yeah, I've sent the photo which you should upload. Please upload that photo and all this one and tag me also. work, please. एक मिनट, I'll get back to you. कब से इशू सब शुरू हुआ बोल रहे हैं आप?
10 दिन हो गए डॉक्टर।
हाँ, ठीक है. एक बार इधर आ जाओ.
So she forgot in the middle of her phone calls that she had already evaluated him.
हाँ, ठीक है. Hello. हाँ हाँ. How many likes did we get finally? हाँ, ये prescription उधर लेके जाइए, वो extend करेंगे, ठीक है? हाँ, how many likes? We got some comments also. That's fun. Oh.
So this is known as distracted doctoring. Yes, every one of us have our own mobiles. We have our own Facebook accounts. We have our own Instagram accounts. The number of likes really matter. Even to me, the number of likes matter. And there may be sometimes some emergency thing happening at home for which you need to keep in touch on WhatsApp or whatever mode of communication. But make sure that you take a break. I actually have a protocol in my OPD. After 2 hours, I take a break of 10 minutes. I have something, a biscuit or a water, and at that time I check all the messages. I reply. Just give me 2 more minutes time. Anyway, one speaker is not there, so I make sure that I see that those time I check all those things, but it is 100% mandatory that we don't check our mobile in front of the patients. Never use medical apps in front of your patient. So patients are seeing, ऐसे देखते रहते वो हम क्या कर रहे हैं. So never use, so they know we don't know the diagnosis. Many times there are so many new things which we have to search on the internet. Do everything after putting at least a Ziploc drop. Make the patient sit outside. Then you can check everything. Call him back inside and do the treatment. But patient के सामने mobile नहीं खोलना. So this is something which is, this is my last video, I think, which emphasizes on the empathy. आयु में बैठी, क्या प्रॉब्लम है?
मैडम बच्चा देखता ही नहीं है, मुझे पहचानता नहीं है, क्या टाइम हुआ, किसी को उसको बुलाते हैं तो भी देखता नहीं है.
नॉर्मल डिलीवरी हुआ था बच्चे का?
डिलीवरी नॉर्मल हुआ था मैडम, लेकिन रोया नहीं था बच्चा डिलीवरी के बाद.
फिट्स आया था?
फिट्स 1-2 बार आया था, डॉक्टर को दिखाए थे हम, उन्होंने दवाई वगैरह चालू किया है, अभी तो ठीक है बच्चा.
तो बच्चा रोया नहीं, बच्चे को फिट्स आया था. अरे ऐसे में ये ब्रेन पूरा डैमेज हो जाता है बच्चे का. ये आंख का प्रॉब्लम नहीं है मैडम, ये देख नहीं रहा है लेकिन फिर भी आंख में प्रॉब्लम नहीं, पूरा ब्रेन ही. बच्चे का गर्दन भी नहीं बैठा होगा अभी तक, तो ये चलेगा भी नहीं, बच्चा बैठेगा भी नहीं आगे. हमारा काम नहीं है ये. ब्रेन के डॉक्टर को दिखाइए, आंख बिल्कुल ठीक होगा बच्चे का. जाइए जाइए ब्रेन के डॉक्टर को दिखाइए, जाइए. हमारा कुछ काम नहीं है इसमें. So the last point which I would like to stress is be empathetic. There are so many children like that. There are so many parents like that. There may be an optic atrophy. There may be Leber's hereditary optic neuropathy, where you may know that nothing can be done maximum from our side to the patient, but maybe telling it the same way, in the gentle way, helping them in whatever small way that we can do. A low vision aid, maybe a vision stimulation exercises, putting them in touch with a corresponding neurologist, helping them in every single way is what we are made for. I think with those small words, the patients, it's not that patient may not be bringing much to you, but that patient will go and tell other patients about you, and that will bring more patients and more for us from the professional point of view also. So be empathetic. The special situation would be taken up by Madhav Ambekar sir. I wouldn't be stressing with it. So finally, I would like to say is we practice what we learn. Good communication means half of the treatment done. So the rest of the treatment is just writing maybe loteprednol, fluoromethanol or whatever rest of the thing. But it's the communication which takes up 70 to 80% of our practice. So all the best to all the young ophthalmologists over here. With this, I see if you can take back even a few words, we would be really happy. Thank you.
Thank you, Dr. Deepthi. That was a very illustrative ideas that the PGs should actually learn. So thank you very much. Now we have Dr. Madhav Ambekar, who will be breaking the bad news. The bad news is, Dr. Ambekar, you have only 10 minutes because Dr. Quresh is coming.
Okay, that's right.
And he is the showstopper.
Yeah.
So this is a very important topic because that is where it differentiates a very good doctor from an average doctor. It's not about telling the good news. Anybody can break the good news. But how to break the bad news is something that really defines your character as a doctor. Dr. Madhav.
Yeah. So I think breaking the bad news is like communicating वो तोता मर गया है. You know, most of us know that वो तोता कैसे मर गया है, because finally unless you communicate कि तोता मर गया है, वो राजा का बड़ा प्यारा तोता है, तो वो कैसा मरता है, तो नहीं वो हिल नहीं रहा, वो डुल नहीं रहा, वो खाना नहीं खा रहा, वो पानी नहीं पी रहा, काइंड ऑफ अ थिंग. सो फाइनली what is required is how you communicate about the bad news, what a nucleus drop, not putting the IOL or anything. As everyone has said, right from KP and everyone has said, and what Dipti was saying, probably for me, hairs being already white, I think for me it's a cutting edge. So whenever I try to communicate, it is been accepted fairly well. So first and foremost is you have to be a good listener, as everybody has said that before, because see, before you break the bad news, patient is not directly on the table and with the complications on. Patient has already reached to your OPD. So it starts right at the front desk. So unless your front desk gives you a proper treatment, because one single small negativity would always give you a bad impression to the patient. So effectively, it is everybody from the front desk has to be a good listener, and that's the most important part of the success. And success is in terms of good work and good repute, both. It's not only in terms of money what you earn, it's all what you get as number of patients. I think number matters more. Money is automatically a byproduct of the whatever number of cases you see. So you have to be a soft spoken and gentle before you get it. As I said, that first visit, getting connected is most important. Your front desk will always give the person a correct perspective, that banda aaya hai, you talk to the fellow and he would give you properly communicated everything. As he has said, that the time required, he might have started from the home, there may be a traffic jam and n number of things happening, and he would be saying that I left 2 hours before. So instead of saying that way, you try to make the patient comfortable once he is inside, and once he enters your premises, everything is on your head. So it is your responsibility to communicate it properly. So you have to be a patient listener, avoid attending the phone call, as Dipti has correctly said, and focus on the patient's issue and do not think of the chair time. Because everybody thinks that chair time is the most important. 1 minute, 2 minute, 2 minute में 2 patient होना चाहिए. It's not the case. And counseling makes the main crux of the story. Get yourself trained into the reach out to the root cause of the complaint. And you are a preliminary and eye surgeon. You may be a retina fellow, you may be a squint fellow, but finally patient will come to you as an eye surgeon. He doesn't know that any kind of a loss of vision is because of retinal problem or refractive error or anything else. So you have to be very patient in listening. You cannot say, I remember one of my fellows saying, sir, mere paas glaucoma ka patient utna nahi aata hai. I am a glaucoma consultant. I said, but then unless a patient reaching you at the age of 40, he would come for the presbyopia correction. How can he understand that you are a glaucoma fellow? So you have to be considering yourself as a primary ophthalmologist, and then you are a retina fellow or a glaucoma or pediatric ophthalmologist, everything. So let the patient get confident in you and try to read the body language. So you have to get socialized with the patient about unless you are I am a small town practitioner, so every action is judged by the society at large. For everything you communicate or whatever you do in the society is taken in a different stride at the smaller towns. It may not be for Quresh because he is in metropolitan city. So whatever Quresh does in between, I think it's a different story for Quresh. So every small habit of yours is considered properly. So you have to be very particular about presenting yourself in the society at large. And technical and commercial counseling, as I say always, you have to start. Technical counseling is a different thing and a commercial counseling is a different thing. As Dr. KP has correctly said, that you have to give not a huge number of packages, 23. वो उतना बड़ा डोसा नहीं चाहिए. So you consolidate within as short as possible, that you can, because everything it matters before you break the bad news. Because my standard way of counseling is that MH370, which has lost somewhere about 8 or 9 years back, is not yet found. Where people know that aviation industry maintains the highest standards of the cross checks and checks everything. So whatever we do, 1% chance है कि मेरे दुनिया के सबसे अच्छे सर्जन के हाथ से भी कुछ भी हो सकता है. Anything can go wrong is the entry word for every counseling. So if you have a proper counseling, you can break the bad news properly, and you try to correct them through the job which they have been doing it. So whatever जो भी बंदा कुछ कर रहा है, as a teacher comes to me, I say कि तुम्हारे पास आने वाले 100 बच्चे हैं, you cannot assure that every person would go to medical or the engineering. There are people that who may not go for medical engineering because finally it's your job to train. But exam में तो उस बंदे को ही लिखना है. So effectively it is important to understand that you starting of the counseling is a starting of the breaking the bad news also. And as he has said, give the bird's eye view. Nucleus नीचे गिर गया, ये हुआ है, वो everything. वो जगह नहीं था is the correct word. What I also use for last many years कि वो जगह कम था, वो लेंस बैठा नहीं है, but we'll try to do it as a second sitting. If we ER fellow is not there around, always I say कि वो second sitting में बैठ जाएगा, and that's a standard entry level of the counseling even for everything before I break the bad news, and encompassing all possible problems as I said, जो भी हो सकता है, end ophthalmology भी कुछ भी हो सकता है, पूरा आग चला जाएगा, but then you have to communicate it in a way कि in a nutshell, but at the same time be assertive and affirmative to say कि what is likely to happen. As I said, that guarded prognosis is one thing that you have to communicate it properly, and hyping out the unrealistic outcome. Chashma ही नहीं लगेगा. The moment you say trifocal and anything and chashma ही नहीं लगेगा, and even if the fellow has a 6-8 vision, he has hundreds of grudges against you. So always make them understand that I am also more in favor of monofocals unless patient specifically asks for the multifocal. So, and it is always a patient's expectation that more amount is paid, there are more expectations. So try to cut down on their expectations right from the beginning, which will always help you to give the proper counseling for the further things if there are any complications. And getting confirm about the patient, the relatives, to understand the technical aspects of the problem and transfer the patient for the commercial counseling to someone else, because then that is not your job. But then I have always thought that technical part is to be told by the doctor as much as possible, and commercial you can leave to your counselor as he can do it. And as I said, the breaking on the bad news, giving the baseline idea at the correct time when the patient is in the most receiving way, as he has correctly said, कि बीच में बाहर आके between the two cases you come out and you tell everything that whatever has happened and we are trying our level best. But it's keeping your own calm is the most important thing. If your face shows that you are panic, I think it's gone. So you have to be keeping your face very calm and quiet, and as much as normal situation for yourself, which will ease out the patient's relative also. And immediate post-op is the best time. Dilute the story, but do not dilute it to that level that वो पूरा पानी बन जाए. So an optimum dilution is required, and certain things are left between the lines. But as I said, it has to be assertive and a meaningful thing. So effectively, yes, it can happen. It's not that bad. हो जाएगा. ऐसे कोई चिंता वाली बात नहीं. 2 दिन के बजाय 2 हफ्ता लग सकता है. And as I always say कि topical or whatever may be the case, always give at least 2-3 हफ्ता लगेगा. Because it is always expectation कि उसको तो कल से दिखने लगा है. मुझे 2 दिन extra क्यों लगा? And because nowadays everybody is in so much hurry, कि everybody wants कि second day, or why second day? Within 6 hours he wants everything going back to the normalcy. So it is important. Nowadays most of the patients are net gurus. So make them aware about the information, wisdom and knowledge. Tell them that what you get on the net is only information. You have to apply your own wisdom to convert that into your own knowledge. Otherwise, एक गाड़ी बनाना तो YouTube पे और इस पे भी मिल जाएगा, how the car is assembled. Even if you are given all the material available for required for the car, you cannot assemble the car as good as it is assembled in the factory. So I always make them understand at the part of counseling कि दुनिया का कोई भी डॉक्टर जो है वो भगवान की दी हुई जो गाड़ी है उसको मेंटेन रखता है. It cannot manufacture the car. So we are, that is part to before we go for the breaking the bad news. Keeping anger under control and assertive communication is most important. I think with this I have absolutely much in time. Thanks a lot.
Thank you, Dr. Madhav, for really, getting the points right in time, and also the exact how to break the bad news and what are the points of it. And now we have the showstopper, Dr. Kuresh Maskati, and he will complete the IC with his probably the most famous or famed talk, that what is the role of wit and sense of humor in ophthalmic practice, and how actually it eases out communication and takes away all the soreness out of our patient-doctor relationship. Dr. Maskati.
Thank you so much. That's a true confession. First, my claim to fame.
No, every year you're putting 40 only. There's something in it. The last 10 years.
That's why I said over 40 years. So now that is applicable. But I just heard the good news from a colleague of mine who was 1 year junior to me in medical college, has after 39 years of a love marriage has actually found somebody else and has moved on. So there is still hope. I might say then next year married for 1 year or something. But do we need this sense of humor in our practice? Because ophthalmology is no laughing matter, and you try and trivialize, and somebody comes with pain and you hoo, that will really put off the patient. So do we really need to be humorous or use wit or humor or be very serious and give the impression that you know everything with so much of wisdom that you have? So why is it necessary to have a sense of humor and some amount of speaking skills? When a patient comes to you, many times he has come to you because he's been frightened by some other eye surgeon. He has gone for LASIK to someone, and that person has been so meticulous. He has done an indirect ophthalmoscopy and he has found 1.5 small holes somewhere, and he has told him LASIK is not for you. We have to barrage this, and we have to cryo this, or we have to laser this, and then we don't know, you might get retinal detachment, and all sorts of things have been told to that patient. So he's come to you frightened. These are some of the patients. Some of them will be frightened by what you are about to tell them. If he is the first person, he's come to you first and you've seen the same thing for the first time, you might want to frighten, not want to frighten, but inadvertently you might frighten the patient such that he will go to somebody else. So we need to put the patients at ease. If the patient is at ease before you start talking to him about his eye condition, he'll be more receptive to what you're saying, because he's come to you, he's tense, he's worried either because somebody's made him tense or his relatives have made him tense, that what is happening, you got red eye, 5 days you haven't done anything, it could be a subcongenital hemorrhage, but he's for 5 days, 27 relatives have told him that ye aankh laal hai, tum doctor ko nahi dikhaya. So he's already tense about what is going to happen. So put the patient at ease. So first thing you do, if a subcongenital hemorrhage patient walks in and he says this, so put him at ease. Nothing is going to happen to you, your eye is fine. So start with something like that, he'll be more receptive to everything else. And remember, at least in the beginning when I had a huge competitor across the waiting room, in my practice when I started, there was this gentleman called Dr. B.T. Maskati, who was sharing the same waiting room and same secretary with me. So I had huge competition. I relied on my speaking skills that I had half an hour to convince the patient, while Dr. B.T. Maskati had 3 minutes to convince, because he had 30 patients waiting, I had 3. So use that deficit that you have as your strength. So before your surgical skills become known, people don't know how great a cataract surgeon or glaucoma surgeon you are. But your speaking skills, you've got more time, use that time, spend time, don't bug out the patient from your clinic, because you've got nobody else waiting there. You have to read a novel after that. So you might as well spend more time with the patient. Therefore, your speaking skills have to develop, because that will set you apart from a busy competitor. Explain with examples so that they can understand. Don't be in a rush to use fancy gadgets like people have a laptop there, an iPad, they put the iPad on, see the eye, this is the picture of the eye, this is your retina, this is this. I don't use that. I tell them that, the cornea is like the watch glass of this phone, of this watch that I use. Of course, mine is a Rolex watch. You may not have a Rolex watch, but the watch glass is still the same. So I'm using a little bit of humor, I'm self-depreciating, talking about my Rolex or whatever, but telling them that unlike my Rolex watch, the watch glass is flat with my Rolex, but your watch glass, the cornea, is a little dome shaped. So I'm using examples that they can understand. Then I tell, if it's a youngster, I tell them, in the good old days when I took pictures, there was a camera which had a film at the back of the camera. You may not understand this, but your parents will know where the film was. So in your parents' camera, where the film was at the back, that is where the retina is. So these are little bit of humor you use. You can easily show a picture of an eye there, but explaining with things like that gets them a little more jovial and therefore more receptive. You can use models, you can use color atlases, you can use software on treatment, but the humor should be very subtle. So this is the type of humor that I'm talking about. So comparing it with a camera, the retina at the back, and telling them that you only use mobile cameras, but there were other cameras in those days, and things like that. So gets them into the thing. You don't have to tell jokes. Please never tell patients jokes, because it is out of bounds. It has got nothing to do with the subject, and they think you're a joker. So using humor and telling jokes are two different things. So not a single joke should ever come out from you, no matter how free you are. So let's take a few practical examples. So if patient comes to you for cataract, doctor, is my cataract ready for surgery? So now what is ready for surgery? So I tell them it all depends on your personality. I tell them that if Mr. Mukesh Ambani came to me, his cataract would be, and his cataract was like yours, I would say it's ready for surgery, because tomorrow he has to sign $1 million check and the government may fall if his check signature differs. So for him, his cataract is ready. But if his mother came to me for cataract surgery, I would say that we could wait a year or two, because she only wants to see the big print on the Bhagavad Gita, which is nice and big. She's not interested in TV. So for Mrs. Kokilaben Ambani, it's not ready for surgery. So I convey to them that cataract being ready, I can operate your cataract at any time. I don't tell them even when it's not there. But I say that I can operate your cataract at any time, but it needs to be your choice. So I said in the previous days, we used to have mature cataracts where you couldn't see the fingers in front of your eyes. That time my father used to say, get the cataract surgery. And until then he would say, come back next year. I said, because we were afraid that breaking the cataract in the eye would cause all the lens material to strew out, and therefore we would wait until it was so stuck to the capsule that I could pull out the whole cataract. And I compare that to a shop. Usually a lady comes with a purse and I pick up that purse and say, it's like your purse. If it's well stuffed inside and I pull the contents, the purse also comes out. We wanted the purse with the contents. But nowadays, what we were afraid of doing earlier, we are actually doing. We're using an instrument, and then I take out my pen and show them that phaco, the tip vibrates at so many times per second, and it breaks the cataract up. But we don't allow the contents to strew. We suck it all out before that happens. So the technology has changed. So we can operate you tomorrow, but it's your choice. So then I tell them the truth, but I tell them that, and I said, if you're unhappy with your vision, we can operate it earlier. Next question. Doctor, you'll be doing my surgery by laser, no? Now, their concept of laser is different from your concept of laser and our. So I tell them that what people commonly call, I don't have femto. So I tell them that I convert that into my strength. So I tell them that what people normally call laser is what I'll be using. But I said people don't know how to pronounce such long words like phaco emulsification. So they use a 5-letter word called laser, which means the same thing to most people. If you there is actually a small segment of my eye surgeons who actually use a physical laser. As of now, I don't see the advantage, so I don't have it in my practice. So I'm telling them absolute truth that I don't have the laser. If I were to have it in my practice, I would be operating you in, doing laser in one room, then putting putty on your eye, then physically picking you up and putting you in another room, and then proceeding with the rest of the surgery, which is phacoemulsification, which at the end of the day will give the same results. So I'm not downgrading anybody, I'm giving them facts, I'm telling them I don't have this machine. As of now, I don't see the advantage, because I'm leaving it myself open. Tomorrow, if I purchase a femto, my story will be different. But as of now, stick close to the truth, but use a little bit of humor. Doctor, which IOL is best? Now, either you have a counselor like Madhav Ambekar has, I don't have a counselor, I do everything by myself. So, which IOL is best? So, I tell them that, look, when you go to a restaurant and you ask for kali dal or you ask for yellow dal, you are the master because you've tasted both. So, you know which is better. Even if the waiter tells you that kali dal is 100 rupees and yellow dal is 150, you will choose the yellow dal because you like the taste more, irrespective of the price. But I said, if I were to tell you that you want IOL X or IOL Y, X is 100 rupees, Y is 150, you will turn around and say, doctor, which one do you think is best? So I said, leave it to me. I'll put the best IOL possible for your eye. Forget about it. This is the package. I have a single package. I have a single package for monofocal and I have a single package for premium. So I tell them that this, first we discuss monofocal versus multifocals and all that. If they are 90% of the patients are for monofocal, by the time I tell them the price. So then it's, in monofocal, we don't discuss brand. 95 to 99% of my patients only know which IOL has been put in the eye when they receive the sticker. So they don't know whether it is going to be Alcon or Rayner or whatever. So depending, when they bargain with me, so I tell them that my package price is this. Now my package price which I'm quoting is for a imported IOL. They bargain, nahi doctor sahab, hum to abhi taxi chalate hai, hum abhi 2 mahine se band hai. So in my mind, I have downgraded it and chosen. So I tell them, all right, for you as a special, this thing is a concession, we'll do it in X divided by 2 price. So I have given them 50% concession. I have changed the IOL in my mind, but it's all in my mind. Don't worry, I will use the best possible IOL for you. And then you do no wrong. So stick to as close to the truth as possible. You will use only drops anesthesia, no? Because they've heard of topical anesthesia. Now, I don't do topical. I'm not here to discuss the advantages. I don't do topical. How do I convert that into my strength? So I tell them, if you want, we can do drops anesthesia. I have absolutely no problem with that. But please understand one thing, that during this thing, you'll have to look into a light. I will keep firing you. You're not looking to the light. Abhi dekho, light mein dekho, kya kar raha hai? This is what I tell them. That these are the sounds you will hear when I'm doing the procedure. And of course, if something goes wrong, I will blame you, saying that you did not look into the light. The choice otherwise is for me to give you a little injection which you will forget by the time the surgery is over. It will require my putting a putty on the eye, which will make your eye safe for one day. 24 hours later, I will open the putty and everything will be all right. The choice is yours. Nobody has chosen topical after that. Next question, you guarantee I will not need glasses after surgery. So they come to you looking for guarantee because somebody else has guaranteed this. Now I cannot guarantee something like that. 90% of my patients are small incision cataract surgeries. So how can I guarantee no? So what do I tell them? I still want to keep the patient with me. So I said, can I guarantee that when you cross the road, you will not be hit by a speeding truck? I can't guarantee that. Can you guarantee anything in life? I said, ऊपर वाले की चोपड़ी में जो लिखा है वो लिखा है. So I can't guarantee anything, but I will try my best. I will give you full attention. I will try my best to see that you can get as close to no glasses as possible. I tell them sometimes glasses are also helpful in the sense if I give you a small number where you don't have to wear glasses all the time, but you can see more, because most of my patients get minus 1.5 at 90, which is all right because they can see their mobile without glasses. So I tell them that most of the time you will not require glasses. If you really want to see something well, you may require glasses. So I don't guarantee this, but let's see what will occur, because we use sophisticated computers, I tell them, to calculate so that you don't need glasses. But your eye doesn't behave like my computer expect it to behave. I'm not blaming your eye. So again, little bit of humor, that I won't blame your eye if you get a number. But sometimes the eye, not being a computer, it doesn't understand that computer ji ne bola tha aisa hoga. So you get a little bit of number, but that's only to see clearly. So convert your weaknesses into your strengths. Don't lie to your patients, but use humor to cover the gaps. So we have time, you tell me. Okay.
I think the next session is, there are people already here.
Okay, fine. So you can see this in different situations where they come out with all sorts of, I'll sum up.
1 minute.
Yeah, so you find this in different situations where people will ask you questions like this, and you need to use humor to restore this. Again, the capsules for ARMD. So they ask me, will this cure my ARMD? And I tell them, look, the pharma company also has to survive. So please use their capsules. They are saying that it will help you. It will prevent your retinopathy, macular degeneration going up. Let us trust them. Buy shares in the company if you are using it for more than 10 years. So things like that. So you use this, and just imagine patients asking you questions and dream up some of these answers like this. And this is of course only meant to guide you. Everyone has their own individual way of talking. So as Madhav also said, smile when they come in and smile when you say thank you to them when they are leaving. Thank you so much.
Thank you, sir. I think that says it all. Thank you very much for all the people who attended the IC, and I thank all my co-speakers for making this IC such a successful one. So it's all about communication. Communicating well probably puts us into the right spot in practice. Thank you very much, AIOC, for including us in this conference. Thank you so much.